So when I was a first-year medical student at Harvard, Jerry Avorn, one of our professors, gave me Jack Wennberg's article about variations in practice and spending in Vermont, 1973 article in Science. The article revealed tenfold differences in the rate of surgery across the identical communities within Vermont, twofold differences in the rates of spending across Vermont. Of course, I was convinced at the time that we were spending too little on the low-spending communities, but when I had the chance in my residency and fellowship training to start doing research on healthcare, I realized that Jack Wennberg had moved to Dartmouth, and that he was doing research using the large databases that Medicare had put together. And I thought, boy, if I could ever work with someone who's asking such great questions with data that would let us really provide insight into what's going on in the US healthcare system, I should try to do that. A position came up at the VA, and I applied for the general internist position. I came back to interview with the VA, and I asked Jack if I could work with him. And he said, no, he'd never mentored anybody. So no, I can't promise you anything. Mike Zubkoff, who was chair of community and family medicine, said, Elliott, why don't you come? I'll give you an office near Jack's. And within about a month of getting here, Jack and I were working together. He asked me to go give a talk in Wales. We started writing grants together. And I have to pinch myself about how lucky I've been to have, such a great partner in this work. Well, one of the insights that Dr. Wennberg had early in his career was that you could apply the tools of epidemiology, of classical epidemiology, which is about the distribution of diseases in populations, and what explains why some people get sick more frequently than others. And you could apply those tools to understand the healthcare system. So what Dartmouth has done is to take these databases of insurance claims from the Medicare population, which allows us to understand who lives in every single part of the country, who's over 65. We can then track what care they receive, how much money is spent on them, and what their outcomes are, using the insurance databases prepared by Medicare. So it was the first time that anyone was able to bring transparency to the performance of the US healthcare system across the 300 markets that we defined in the course of that work. What you learn is when you look, so how frequently are people hospitalized in one place compared to another? Well, threefold differences across communities in the frequency with which identical patients are hospitalized. What about rates of surgery? How frequently are men subject to prostate surgery or women subject to hysterectomy in different communities in the country? And what the data revealed was that there are dramatic differences that cannot be accounted for by the health of the underlying population, which leaves the explanation lying somewhere in the organization and delivery of healthcare. And that set an agenda for research that's kept us going for the last 30 years. What explains the differences we see in rates of surgery across communities? What explains the differences we see in the frequency of hospitalization across communities? What explains the fivefold differences in the rates at which identical patients see a physician in different communities? And then, of course, the important underlying question that's raised by that is, so which rate is right? If they're so different, which rate is right?